start. So, oh, okay, sorry, let me just see that. Can everybody see my slides? Mm-hmm. Welcome everybody, and today what we'll do is we've got 4 presentations, and then we will have questions at the end, and I'm just putting my timer on then. And the topic of our conversation is the global impacts of lifelong or chronic respiratory conditions, starting with asthma, but we will consider also COPD. And we want to look at both the burden, but really offer you hope and talk about solutions as much as possible. We're going to start with asthma because not only is it an important chronic condition for adults, but it's the most common long-term condition for children. My name is Sian Williams. I'm the Chief Executive of an NGO, a charity called International Primary Care Respiratory Group. And in particular, I want to talk about our social movement for change, Asthma Right Care. So IPCRG, we have a vision of a global population breathing and feeling well through universal access to right care. And we want to work locally because every context is so different, but collaborate globally so we efficiently use the knowledge that's generated through research and education. And our definition of primary care includes family medicine, but also community empowerment, multi-sectoral action, and integration between public health and primary care. And you have here some images of our colleagues in different parts of the world. Because we reach 155,000 primary care colleagues through our 37 country members, and they're in high, middle, and low income countries. What I plan to cover today is to start with the personal burden of chronic respiratory disease, to then define what we mean by that, then look at the hospital burden or the health service burden, in particular hospital admissions, then look at the high level of population societal burden, and then start to address what we can do about it. And then I will hand over to Anna and then other colleagues who will talk about the solutions, and particularly from Latin America. I don't know whether we're recording this, but anyway, the plan is to record so we can offer you both the slides and a recording afterwards, if that's helpful. So let's start with the personal burden and to try and think of all our senses. Here's a person from Pakistan really suffering from asthma. But let's look and listen now to the video or the sound from, it's not working, sorry about that. The sound isn't working, having worked before. What this would have done is get to hear the sound of a child wheezing, and just to think about how frightening it is to hear the noise of a child being unable to breathe. And that is important to remember, that sound of breathlessness, that sound of people being unable to breathe affects many decisions about people seeking care. I also want you to look at the lungs and marvel at how beautiful they are and how fragile they are. These are illustrations from a new film that we've created called How We Breathe. And on the right, you can see the lungs and the bronchial tree. And you can see how the bronchial tree branches and branches and branches till you get these very fine air sacs, which you can see on the left-hand side. I say this is an illustration. And you can see how beautiful each air sac is, and that's the place where the oxygen is transferred into the bloodstream. And if we damage these, then the oxygen is not getting into the body. I'd now like us to think about what it feels like to be breathless. So if we were in the room together, I would hand out to each of you a paper drinking straw. In this case, you just have to imagine it. And what I'd like you to do is imagine you're putting this drinking straw in your mouth, And then try and breathe through it. Breathe in through it and out through it. So I'll demonstrate. So if you're breathing in, so you have pursed lips. If you could all try it, you don't have to have your cameras on to do it. You may start to feel a tightness build up here because what's happening is we've narrowed the air tube through which the air can travel. And that's what happens in asthma and COPD, that we get a narrowing of the air tubes, the airways. And that not only makes it hard for the air to flow, but it also feels, the tightening feels scary and difficult. Now, I'm not sure whether this is going to be able to play. Let's try it. In terms of the video, I think it's something to do with Zoom not recognizing it. I'll try and play it outside afterwards. But what I wanted to show you was that we get the shrinking of the air tube. But it's not just a shrinking from the outside, it's the inside gets inflamed. And it's the inflammation on the inside of the air tubes that's the main problem with asthma. There's a swelling on the inside of the air tubes. I'm just going to try and take it off the PowerPoint and see if we can, well, I think I'll show that at the end to see if I can get you to see the
I'm sorry for interrupting, but maybe if you get out and come in again, because you have to put a check in the screen.
Yeah, I did try that, Javiera, but it just didn't want to. It didn't want to work. I don't know why.
Xian, don't put in full screen.
Yeah, let's try that.
Yes.
So that's going to work. So let me just share my screen. And again,
our bodies when we get breathless. Most commonly, the airflow gets slowed down because there's an obstruction somewhere in our airways between our nose and air sacs. There are many reasons why they may get obstructed, and knowing the reason helps explain the diagnosis. These are the main types of obstruction. The most common reason for obstruction is swelling or inflammation inside our airways or tubes. It happens in asthma and bronchitis, the main cause of COPD. The lining and walls of the tubes are damaged from persistent or recurrent irritation from common irritants such as tobacco or cooking smoke or allergens. This leads to inflammation. Mucus containing dead cells or bacteria, phlegm, can also build up because the cilia can't sweep it away. Coughing is our body's attempt to clear this buildup. Obstruction due to muscle tightening, forcing the tubes, our airways, to close up. For example, in an asthma attack, bronchospasm, the muscle around the bronchi or bronchioles tighten, bronchoconstriction.
So that's just an image, and it's something that everybody can have a look at. I will just go back to this one to see if we can get this one to play. This one doesn't want to work though, so I apologise for that. So I'm now going to go back to look at other types of burdens. So being breathless can be scary. There are high rates of mental health problems with people with asthma, and anxiety and panic attacks are the most common, and their prevalence is 3 to 10 times higher than the general population. So how do we define asthma? Well, people may experience wheezing, breathlessness, chest tightness, or cough, or people may be symptom-free at some times. So it gets diagnosed by doctors or defined by doctors as variable because experience varies day by day. Lifelong, it cannot be cured, but it can be controlled. One of the defining features is this long-term inflammation of the air tubes, and therefore, and I've highlighted this, an anti-inflammatory inhaler is essential because you have to tackle the inflammation. You also get obstruction, as we saw in that film. Again, therefore, an anti-inflammatory inhaler is essential. but also air tubes are more sensitive to substances in the environment, and Javiera will talk more about the environment later. And we also therefore need another inhaler which relaxes the muscle after this bronchoconstriction. And tobacco is an important trigger. So to summarize where we've got to, it's a biopsychosocial problem. That's to say it's biological, there is a mental health component, there's a social component, because people with asthma can get scared and they have to recognize they have a lifelong condition. And the good news is that it needs a biopsychosocial response, and primary care has those skills to develop that and to respond to that. And therefore, target 3.8 of having universal health coverage is really important. Let's move up a level to the health service burden. So the most important factor in health service burden is hospital admissions, because they're preventable, but they are still very common and lead to significant cost. So unpublished figures from Malaysia that colleagues have shared with me very recently suggest 1 in 10 of their cohort of people with asthma were hospitalised in the last year. In Uganda, colleagues have said, well, actually people make a choice. Do they take a risk and risk a hospital admission, or do they take a year's supply of medicines? Actually, probably you can afford 2 hospital admissions for the same price as a year's supply of inhalers. It's maybe worth the risk. And in the US, in a survey of people with well-controlled asthma, 1 in 7 reported having an emergency department visit or urgent care visits. They may not have been admitted, but they went to the emergency department. So there's significant use of hospitals. And there's a huge variation in that. And what this slide says, and it's taken from a UK Atlas of Variation, is that variation in here, the dark blue, is associated with socioeconomic deprivation. The other problem is that there's no quick test to diagnose asthma, so it depends on a skilled workforce. But also there's a vicious circle. If the workforce hasn't been invested in, then there may be underdiagnosis of asthma because there's no simple test. Therefore, there's no data. Therefore, nobody can convince policymakers that there's a case to invest in chronic respiratory disease and asthma in particular. But if there's no investment in primary care, then primary care may choose to work in the fields where there is incentive, for example, diabetes, and therefore there's underdiagnosis, and the vicious cycle continues. So it's biopsychosocial, it needs a biopsychosocial response. There's an over-reliance on episodic acute care. Some of the reasons for that include lack of diagnosis in the community, so people are attending hospitals and that's the first time they're being diagnosed. There's a lack of investment in primary care. And so really what we're saying is when the services aren't going where the people are. If we look at that population level, at a global level, the estimate is of about 350 million people with asthma and a prevalence of about 4.5%, but huge ranges in that. And Javiera, Anna and Sergio will tell you a bit more about Latin America. Children, it affects about 14% of children, again, big ranges. It's spread across high, middle and low income countries. But the greatest burden is in lower middle income countries because of the lack of access to appropriate care and treatment, to right care. Here is a tree plot from the Global Burden of Disease. And this is about years of life with the disability in Southern Latin America. So it's 2019 Global Burden of Disease data for the age group 5 to 14 years. And you can see asthma there is a really important factor in years of life lived with disability. And it's still there and important for all ages. The trends aren't going in the right direction. So the trends are getting worse. So between 1990 and 2019, deaths per 100,000, we're seeing an increase in chronic respiratory disease and respiratory infections. And one important and memorable fact is that about 1,000 people die of asthma every day. It's not as big a figure as get quoted from other disease areas, And this is part of the problem with target 3.4 of the SDG, that we want to reduce mortality, but much more importantly, we want to reduce disability and morbidity. And one of the important contributive factors is tobacco use. And again, the trends are heading in the wrong direction. This is data from Korea, looking at on the two graphs, on the left-hand side graph, looking at combustible cigarettes, and then e-cigarettes on the right. And you can see that the paler green line on the left shows people with asthma, and they have significantly higher rates of smoking. And you've got different colours on the right-hand graph. But again, the orange is about people with asthma, and the yellow is people with asthma. So higher rates of tobacco use in people with breathing difficulties, which feels a bit odd, but the data's been borne out in Canada as well. And the e-cigarettes are an increasing problem and are an important trigger for asthma attacks. And yet we can help people quit. And so target 3A of the SDG is really important. There's growing inequality in lung health. This is US data. And what it's showing is that because exposure to tobacco and to air pollution in higher quintiles or less deprived areas has reduced, their lifespan and their quality of life has improved, but the people with the lower socioeconomic groups are still exposed to smoking and air pollution, and so their prevalence of breathlessness and wheeze and cough has not decreased. So the burdens include unwarranted variation, harm, failure to prevent disease, disability, and death. And a waste, because we're using hospital services that could be used for other things, because primary care could do this job if we invested more in it. And there's inequity, because it is the poorer populations in high, middle, and low-income countries who are suffering most. So the important thing from this really is that we focus on disability and we do something to reduce that. And we've got the medicines that can work. The anti-inflammatory medicines can work and reduce this problem if everybody has access to them. So what can we do about it? Well, if this is a slide, a fishbone diagram, which tries to represent the WHO building blocks, but in addition, I've added two more and adapted it a bit. So the first fishbone, if you like, the first building block is environment, and that's not on the original WHO building blocks. The next is information. Then access to asthma medicines and nicotine replacement therapy for smoking. The health services and workforce, financing, leadership and governance is another big fishbone. And then personal factors. And if we want to be swimming towards asthma right care, we need to be tackling each of these. And with the environment, we've got to think about exposures, as I've described. We also need to think about environments conducive to physical activity. With information, we need to be thinking both at the level of the health system in terms of, or the service in terms of the medical record, making sure that we're picking up people who are attending emergency departments. They need to be followed up in primary care, but also good basic public information about what is asthma, explaining that it's an inflammatory condition. Asthma medicines, we need to have these accessible in the right places, but we need to make sure that they're stocked in pharmacies, but over-the-counter sales are managed, because we have lots of evidence of over-the-counter sales which are unhelpful. In terms of the health service, we need to invest in primary care and make sure people are both confident and competent. In terms of financing, leadership and governance, we need to tackle misuse and overuse of medicines. We need to make sure it's easy to do the right thing. And what we would say is value followership. The leadership is important, but we want people to follow good practice. And we've got some great examples to share. And the personal side of it, we need to really try and understand this biopsychosocial impact of asthma We need to value patient experience and help people understand what their concerns are, which might be about the medicines or might be about having a stigma associated with asthma as a lifelong condition. With the environment, the important thing to know is that we have such a thing as bad particles, and Joanna and Javier will come on to describe this. And the smallest particles are the ones that reach really deep down into the lung. But that works on the good side as well, because we have good particles, and those are the molecules of an inhaler. And if those are used right, they get all the way down, right down into the lung as well. The information, we need to tell a positive story. So if somebody has asthma, their bodies are reacting naturally, maybe too much to their environment. We need to teach about inflammation first, then bronchoconstriction, because that helps people understand which inhalers to take, and to trust and respect and be reassured by primary care. And then Leventhal, psychologist, has talked about these 5 questions patients may have. What do I have? What caused it? What's the timeline? Can it be cured or controlled? And what are the consequences of my treatment decisions? And every clinician needs to be able to answer those for the person in front of them. We need to improve access to medicines. WHO Essentials Medicines list includes all we need to manage asthma. But the reality is we have insufficient supply of the bumetanide, the inhaled corticosteroid. We have to improve the supply chain. We have to improve the workforce, as I've said many times, and hopefully pick this message up by investing in primary care, because it can deal with 80 to 90% of an individual's needs over their lifetime. But it has to be decent quality. And we'll come on to show you what we've been doing to try and raise and improve the quality in primary care. It can be done if with finance, governance and leadership, and Finland is an extremely good example. If you look here at the turquoise bars, those show the decrease in lost productivity, and the purple bars show the decrease in hospitalization costs over time due to the investment in a strategy that began in 1987 to invest in primary care and outpatient services. So what can each of us do? Well, we can talk about asthma. There's lots of talk about other NCDs, about diabetes, cardiovascular disease, cancer, mental health even, but not very much about chronic respiratory disease. For asthma in particular, we really need to get the message across that it's an inflammatory disease, because that requires an affordable anti-inflammatory solution, plus emergency care, which involves a bronchodilator. Every system is different, and we need to look at the areas where there is highest need and highest prevalence, and that typically will be in socioeconomically deprived areas. And therefore, we must involve other stakeholders to understand their perspective and what they need. The people with asthma, healthcare professionals, and policymakers, and then measure the impact of our conversations and our investment. So that's the end of my introductory talk to explain about the burden. And I will try and share those films with you again. But let's move on now I'm going to hand over to Anna to talk to you about the Latin American experience. Thank you, Anna.
Thank you, Jan. Okay, you see? Sergio, ¿se puede ver?
Perfectamente.
Bien. Bueno, buenas tardes, buenas noches a todos. Ahora pasamos a hablar en español. Yo soy Ana María Stock, la directora médica de investigaciones en patologías respiratorias y coordinadora del grupo GANOA, y actualmente vicedirectora del departamento de asma de ALAT. Yo lo que les quiero mostrar en esta presentación es por qué tenemos que incluir las enfermedades respiratorias crónicas, en especial el asma, como parte de los objetivos sustentables de la ONU. ¿Por qué? Porque Latinoamérica tiene aproximadamente 600 millones de habitantes. Y en Latinoamérica en Latinoamérica, EPOC y asma son una de las enfermedades crónicas de las más prevalentes. Fíjense, EPOC tiene aproximadamente entre 10-15% de prevalencia en la población total de Latinoamérica y asma tiene una gran variedad, una biodiversidad, como dice Eric Rudd, una gran biodiversidad en todos los países de Latinoamérica, con una variación estimada entre el 10 hasta el 30%. Hay países en Latinoamérica que la prevalencia de asma es mayor del 30%. Esto es un gran problema de salud. Y no solamente es un gran problema de salud, sino que en consonancia con parte de no pobreza de los objetivos sustentables de la ONU, ya en el 2021 se veía cuáles iban a ser los países que iban a aumentar el nivel de pobreza en el año 2022. Y por ejemplo vemos como México, Colombia, Paraguay, Brasil, y en este momento también lo incluiría Argentina, estamos aumentando el nivel de pobreza de la población. ¿Por qué es importante esto? Porque si ustedes ven las causas de muerte, las diferentes causas de muerte en diferentes países de Latinoamérica, la mayor causa de muerte son las enfermedades no transmisibles. Y dentro de las enfermedades no transmisibles, la mayoría de esas enfermedades son de causa respiratoria. Esto, ¿por qué lo de la pobreza? Porque se vio que el asma aumentó su morbilidad y mortalidad, está altamente asociada con aquellos países que son más pobres, porque esto está correlacionado con un menor acceso a los niveles, a los servicios de salud, con mayor exposición ambiental, como ser la polución ambiental. En contraste con las enfermedades cardiovasculares, el asma y el EPOC están aumentando su mortalidad en los recientes años a nivel mundial y en especial en Latinoamérica. En cuanto a la educación, uno pensaría que tenemos que educar solamente al paciente. Y fíjense cómo influye la educación en general, que ya hay estudios que nos demuestran que cuando la madre no superó el nivel secundario de educación, es un factor de riesgo muy importante para que el niño tenga asma. Es decir, que tenemos que tener madres y mujeres con mejores niveles de educación para disminuir también como uno de los factores incidentes en el aumento de la prevalencia de asma en los niños. Y por supuesto, en Latinoamérica se vio que al menos el 40% de los pacientes no tienen compliance, no tienen adherencias con sus tratamientos porque no tienen un buen nivel de educación. Eso es un problema tanto de nosotros, los proveedores de salud, como del nivel de educación en general que pueda tener la población. También es una inequidad de género. ¿Por qué? Porque este aumento de la prevalencia de mortalidad en el asma se da a predominio de mujeres. Esto se está viendo en los últimos años y es sabido que las mujeres en la edad adulta son las que más tienen prevalencia de asma. Ya sabemos que la pérdida del control del asma produce una serie de consecuencias, como ser pérdida de la calidad de vida, pérdida de la productividad, porque una persona que tiene frecuentes exacerbaciones o crisis de asma no va a la escuela o no va a su trabajo, tiene pérdida de la productividad y tiene un alto costo económico. En estudios de 10 países de Latinoamérica se vio que el impacto negativo en la pérdida de la actividad diaria se ve en un 46% en aquellas personas que tienen asma leve. No severa, casi un 50% en personas con asma leve y un 72% de aquellas personas que tienen asma grave ya tienen por lo menos una o más visitas en salas de emergencia. Es decir, que el tener pérdida de control del asma lleva a que las personas tengan un 73% de gasto de los costos del asma que se dan solamente por no poder controlar el asma. Como hemos dicho, tenemos una gran biodiversidad, pero como parte del objetivo de desarrollo sustentable en cuanto a innovación y nuevas infraestructuras, en el asma esto es fundamental. Tenemos que empezar a diseñar nuevas tecnologías, incorporar nuevas tecnologías para lograr un mejor control del asma. Siempre digo que así sea que el paciente viva en zona rural, de lo que nadie prescinde de tener en la mano es un teléfono celular. Esto se da tanto en zonas urbanas como en zonas rurales, en médicos que trabajan en zonas urbanas como en zonas rurales. Entonces tenemos que empezar con el diseño y evaluar de qué manera podemos llegar a través de estas nuevas tecnologías para poder lograr un control o mejor control de estas enfermedades. Y si vemos por inequidad, vemos que acá en este gráfico Latinoamérica es el continente que peor control del asma tiene con respecto a otros países o a otros continentes. No solamente eso, sino que en el gráfico de la derecha ustedes pueden ver en cuanto a acceso a medicación de biológicos que se utilizan para el asma severo, cómo Latinoamérica también está muy detrás de otros países, sobre todo de países desarrollados, en el acceso a la medicación. Y en cuanto ya dijimos que el asma es uno de los grandes factores de desarrollo de asma en estos últimos años, es la polución, la contaminación ambiental, cambio climático. Uno cuando se imagina contaminación ambiental se imagina como esta imagen de la Ciudad de México de la izquierda, que está dada una gran contaminación ambiental por el tráfico, y esto pasa no solamente en Ciudad de México, sino en todas las grandes ciudades de Latinoamérica. Pero en Latinoamérica tenemos otro gran problema, que es la contaminación interior, la polución interior que está dada por la exposición de biomasa. Y ustedes ven acá cómo en zonas rurales de México ya se vio que aproximadamente unos 27 millones de personas tienen exposición a biomasa. Ya sabemos que el cambio climático afecta en gran medida a las enfermedades respiratorias, en especial el asma, pero no solamente el cambio climático. Fíjense en este gráfico en donde en un estudio argentino de adolescentes argentinos se vio que el fumar en forma activa se asoció a un 83% del incremento de asma en este estudio de adolescentes. Es decir que, como dijo Jean, también tenemos que poner el foco en el tabaquismo, la prevención del tabaquismo y cesación tabáquica. Como vemos acá, las metas para poder intervenir en asma, y como lo mostró Jean, son muy complejas. ¿Por qué? Porque el asma es multifactorial, tanto para lograr su prevención como para lograr su control. Tenemos muchos factores que pueden incidir tanto en la prevención como en el control del asma. Por eso es que hemos formado este grupo que se llama GANOA, que es el Grupo Asma NOA, que es un proyecto multidisciplinario en donde intervienen no solamente médicos, sino psicólogos, farmacéuticos, otros profesionales de salud, en donde necesitamos de este tipo de proyectos, igual que Asthma Right Care, que son proyectos multifactoriales que enfocan el asma desde múltiples ópticas. Por ejemplo, vamos a ver, lo primero que tenemos que hacer es establecer alianzas, porque tenemos que sumar esfuerzos. No podemos con un solo proyecto abarcar todo, sino que tenemos que sumar esfuerzos. Esos esfuerzos, desde GANOA sumamos esfuerzos con Sociedad Argentina de Medicina, con Asthma Right Care, con el que tenemos muchas alianzas en Argentina. En Chile también existen alianzas con Asthma Right Care, ya lo va a hablar Javiera, para que podamos intervenir en estos múltiples factores que es el asma. Tenemos otras asociaciones y otras sociedades científicas, ya sea argentinas, latinoamericanas, europeas y GARD, que depende de la Organización Mundial de la Salud, para poder llevar a cabo todos estos proyectos y estas alianzas. Este grupo lo que trata es de diseñar estrategias que sean efectivas en educación, en investigación y en intervención en asma. En educación, lo que fuimos haciendo hasta ahora, tenemos una página web en donde se pueden acceder tanto profesionales de la salud como pacientes, y tenemos capacitaciones a través de lo que llamamos la escuela de asma, como ser el curso universitario de asma grave, un curso para clínicos y atención primaria, cursos para auditores, que son los prestadores de salud, talleres de asma, También colaboramos en educación con Teach the Teachers, que es de Asthma Care, un proyecto muy interesante que es enseñar a educadores en asma en la atención primaria, y realizamos numerosas actividades científicas como webinars, simposios, jornadas. Tuvimos el congreso el año pasado y lo vamos a tener en el 2023, al cual los invitamos a todos. En cuanto a intervención, consideramos que no se puede solamente hacer capacitación y educación, sino intervenimos. ¿A dónde realizamos la intervención? En todos los niveles de la red sanitaria. Estamos realizando capacitaciones e intervención en la atención primaria, en emergencias. Estamos conformando centros de alta complejidad en asma, sobre todo para la atención de aquellos pacientes con asma moderado grave. Capacitación e intervención en farmacias. Elaboramos algoritmos de diagnóstico y tratamientos que estén simplificados y de fácil acceso, en especial para clínicos y médicos de atención primaria. Elaboramos historias clínicas de asma grave a las que todos pueden acceder a través de la página web. Tratamos de lograr la digitalización de estas historias clínicas. Estamos con un proyecto de asma y deporte. Y fundamentalmente estamos con un proyecto muy importante a 5 años, que es la Red Nacional de Asma, para abarcar los 3 niveles, el primero, el segundo y el tercer nivel de complejidad de toda la red sanitaria de atención. En cuanto a investigación, estamos elaborando estudios epidemiológicos y fundamentalmente investigación en el acceso a nuevas tecnologías para el diagnóstico, el tratamiento y el control del asma. Una rama muy importante de GANOA es intervenir en las políticas de salud pública. ¿Por qué? Porque si no intervenimos en los países en políticas de salud pública, todas estas acciones van quedando rezagadas y no se pueden sostener en el tiempo, y muchas veces cuesta obtener el apoyo gubernamental, el apoyo nacional para poder establecer todas estas políticas. Por lo tanto, establecimos campañas de asma, intervinimos y estamos interviniendo en los programas de salud en asma en los ministerios nacionales y provinciales, y fundamentalmente desarrollamos junto con otras asociaciones, con las asociaciones científicas y la Asociación de Pacientes con Asma, la Ley Nacional de Asma Argentina. Esta ley está presentada en el Senado de la Nación, en el Congreso de la Nación, y estamos esperando que se trate para que sea aprobada. Un punto muy importante en todo proyecto tienen que ser los pacientes, porque hacia ellos está dirigido todos estos proyectos. Entonces nos parece fundamental trabajar también en unión, en alianza con asociaciones de pacientes como LOBEXER, como la Asociación Argentina de Pacientes con Asma. Elaboramos materiales educativos para pacientes, tenemos videos de técnicas de los inhaladores y elaboramos las campañas de asma dirigidas a los pacientes. Bueno, todos estos proyectos, yo creo que todos los que hacemos este tipo de proyectos lo hacemos para defender los derechos de los pacientes y establecer cuáles son también las responsabilidades que tienen los pacientes de su enfermedad. Bueno, doy paso a Sergio, muchas gracias. Sergio.
¿Está compartiendo?
Sí.
Buenas tardes.
Sí. Pone en modo presentación.
Muy bien.
Pantalla.
Ahí en modo presentación. ¿Está bien? ¿Correcto?
Ya te digo. No se ve todavía.
¿No se ve?
En modo presentación no.
Ok. Ya entonces.
Oh, mine. Yeah, it's still seeing in there.
Abajo, Sergio, pone en el...
Está el zócalo del Zoom y no me deja.
Hola, tal vez te apretás F5, se pone solo en compartir pantalla completa.
No.
Salí o volví a entrar. Ahí está, ahí está, ahí está.
¿Ah?
Sí.
Ok. Bueno, muy bien. Bueno, buenas tardes. Yo me llamo Sergio Zunino. Voy a hablar de las metas de desarrollo sostenible y su beneficio para la salud en enfermedades respiratorias crónicas no transmisibles en Argentina. Represento a IPCRG, Asthma Right Care en Argentina. También represento a la Sociedad Argentina de Medicina y la Asociación Argentina de Medicina Respiratoria. Nuestro mapa de ruta va a ser este. Vamos a hacer una introducción, hablamos de algunos datos epidemiológicos de importancia y vamos a analizar las barreras que atentan contra la salud respiratoria, fundamentalmente pobreza, la presencia de tóxicos en el aire ambiente y cuáles son las acciones para modificar esta realidad. Vamos a analizar todo lo que tiene que ver con los aportes de IPCRG y de Asthma Right Care en Argentina y las alianzas para un futuro mejor. Luego, al final de las disertaciones, vamos a hacer la ronda de preguntas y respuestas. Bien, en cuanto a la prevalencia y morbimortalidad del asma, Argentina es un país que tiene, de acuerdo al último censo nacional de este año, 46 millones de habitantes. Se estima que entre un 10 al 13% de las personas tienen asma. Es decir, que estamos hablando de 4 millones de personas que viven con asma. El asma es una enfermedad que propone, de alguna forma, eventos de exacerbaciones o reagudizaciones que en muchos casos, cuando no son correctamente tratados, terminan en internaciones, siendo 17.000 la cantidad de internados en el último año. Y además hemos tenido 400 fallecimientos directamente relacionados a asma en el último año. Pero no es la única enfermedad obstructiva con alta prevalencia. También tenemos 14.5% por ciento de personas que tienen COPD o EPOC, que han generado 5.000 fallecimientos en forma directa o por enfermedades relacionadas a esta enfermedad. Es una enfermedad con alto subdiagnóstico y también con un elevado error diagnóstico, un 60% aproximadamente. Ahora, cuando observamos las estadísticas de incidencia, lo que estamos viendo en concordancia con lo que citó Ana es un ascenso en la curva de mortalidad en mujeres asmáticas. Fundamentalmente, como vemos aquí, entre el año 2000 y el año 2020, han ido ascendiendo en esta curva verde la cantidad de fallecimientos en el género femenino. También es importante saber que 6 de cada 100 personas han tenido algún ataque de asma o crisis en los últimos 12 meses y que han recibido también tratamiento para el asma. Bien, ahora cuando todos pensamos en esta enfermedad, ¿cuál es la primera imagen que se nos viene a la cabeza? Probablemente sea la imagen más representativa, que es el bronquio, que está, digamos, casi cerrado, está, digamos, engrollado, a través del cual la persona se le dificulta respirar, porque el aire no pasa con facilidad, y es por eso que a veces silba al pasar el aire. Pero eso sabemos que está debido a que existe inflamación en ese bronquio, que es el que en definitiva lo cierra. Y que si no hacemos un tratamiento adecuado, a largo plazo vamos a tener una lesión fija, es decir, vamos a tener una lesión que ya va a hacer que ese bronquio no sirva más, que ya ese bronquio no nos sirva para respirar y que esa persona tenga una enfermedad severa. Por eso es muy importante todos los pasos que tienen que ver con el correcto diagnóstico y el correcto tratamiento de esta enfermedad. Ahora bien, hay otras personas que tal vez son más leídas y tienen más conocimiento y que tienen la dimensión de lo que es la imagen molecular, que son todas aquellas, digamos, mediadores que intervienen en lo que es la alergia o lo que es la parte no alérgica o eosinofílica que genera, digamos, el desencadenamiento del asma y de las exacerbaciones. Todas estas dos opciones de pensamiento son súper correctas, está muy bien que así sea. Pero, ¿y la dimensión humana? Digamos, el dominio humano, ¿qué lugar ocupa en todo este digamos, esta línea de pensamiento. Bien, para nosotros el asma es una enfermedad que, si bien es crónica y no tiene cura, puede ser controlada, y que las personas que viven con asma pueden ser capaces, si se hace el tratamiento adecuado y la intervención adecuada, de hacer su trabajo, su vida diaria, ir a la escuela, hacer deporte, sino como este niño que está mirando cómo los demás juegan y él no puede porque tiene asma. Es decir, que un niño que vive con asma debe poder jugar como todos los demás. Y un poco ese es nuestro desafío, digamos, de lo que significa posicionarnos desde el lado del paciente. Y esto tiene mucho que ver con lo que viene pasando desde hace muchos años. Hemos tenido una altísima mortalidad en lo que denominábamos la era broncodilatadora, donde sabíamos, a la luz de los conocimientos de ese entonces, que este bronquio contraído, si usábamos broncodilatadores de acción corta, podíamos obtener un cierto beneficio a corto plazo. Es decir, unas pocas horas que generaba un beneficio donde la persona podía respirar algo. Pero eso no quitaba que no tuviésemos ningún tipo de tratamiento sobre lo que subyacía, que hasta ese entonces no se conocía con certeza, y que ya para la década de fines de los 90 se conoció que esto se debía a inflamación. Y ahí empezó a aparecer el amplio uso de los corticosteroides inhalatorios. Esto realmente cambió la vida y la mortalidad. Fíjense de estas curvas de mortalidad tan elevadas, cómo abruptamente descendieron y manejaron una mortalidad muchísimo más baja en adelante. Y mucho después aparecen las asociaciones entre estos antiinflamatorios de opción tópica bronquial, con broncodilatadores, pero que ya no duran un par de horas nada más, sino que ya duran prácticamente todo el día y permiten que la persona tenga esa mejoría en cuanto a la inflamación y en cuanto a la dilatación y pueda vivir mejor. Todo esto es la evolución que hemos ido teniendo en los últimos años, acompañados de los recursos y de la ciencia. Pero muchas veces nuestra persona que vive con asma vive en un mundo con otras personas donde existen un montón de mediadores y un montón de temas en el ambiente que lo pueden, digamos, precipitar a tener eventos de síntomas y eventos de exacerbaciones. En este caso, por ejemplo, el humo del cigarrillo, como bien comentó Ana, todo lo que tiene que ver con los aeroalergenos, epitelios de animal, algunos alimentos, los propelentes de algunos, digamos, productos que son aerosoles, todo lo que tiene que ver con la producción industrial, los humos ambientales, todo esto va generando en la historia natural de la enfermedad que tiene el paciente distintos eventos de exacerbaciones que están ligados estrictamente a esto. Estas personas, en muchos casos, no tienen un acceso completo a lo que es el mejor de los tratamientos. Entonces utilizan tratamientos que son aliviadores, por eso el sobreuso de los broncodilatadores de acción corta, que está muy bien para las crisis cuando la gente va a la guardia, pero no está bien para ser el único tratamiento crónico que tiene el paciente. El abuso de los corticosteroides sistémicos que se usan para salir del paso en estos casos hacen que se utilicen los corticoides inhalatorios. Así vemos cómo el medio ambiente donde vive el ser humano, que está estrictamente y estrechamente ligado con todos los que son los objetivos de sustentabilidad a largo plazo que se propone por Naciones Unidas. Uno de ellos, que son las barreras que tenemos hacia la salud respiratoria, tiene que ver con la pobreza. El Instituto Nacional de Estadísticas y Censo, INDEC, muestra estos valores para Argentina, donde el 37.3%, que representa casi 11 millones de personas, están en situación de pobreza, y el 8.2% directamente en indigencia. En este mapa nosotros tenemos a lo largo y a lo ancho los 4.100 asentamientos que tenemos en el país, que en total cubren una superficie de unos 330 kilómetros cuadrados, que es más grande que la ciudad de Buenos Aires. Una característica de los asentamientos se ve en esta imagen. Fíjense las condiciones de vida precaria donde las personas desarrollan su vida y, digamos, las limitaciones importantes que tienen. Aquí viven muchas de las personas que viven con asma. Pero también tenemos comunidades, digamos, originarias, donde tienen aún peor, digamos, calidad de vida y nivel de pobreza. Otra de las barreras que están, digamos, en la actualidad atentando contra la salud respiratoria es la exposición a los tóxicos ambientales. Esto es el delta del río Paraná. Si recuerdan, para arriba, al nivel de Brasil es el Amazonas. Aquí es donde termina prácticamente y lo que se ocasiona son incendios muchas veces accidentales, ya que se están tratando de expandir las fronteras agrícola-ganaderas en estas tierras y van generándose incendios. Estos incendios son focos muy importantes porque son difíciles de contener y se dan también en áreas que son humedales naturales, de los cuales todavía no tenemos una ley que los proteja. Aquí tenemos el lado contrario, donde tenemos la ciudad de Rosario y vemos la significancia de estos, digamos, eventos. Pero estos eventos no son localizados solamente en el delta del río, sino que también a través del viento van llegando a las ciudades y esto va generando que muchísimas personas concurran a los sistemas de emergencia por exacerbaciones respiratorias, no pueden respirar. Ya de por sí, el aire en Buenos Aires tiene una concentración media anual de 14 microgramos por metros cúbicos de partículas de un material particulado de 2.5. Es 40% más alto que el nivel considerado seguro según la Organización Mundial de la Salud. Esto ocasiona que 85 niños fallezcan al año por enfermedades vinculadas a este fenómeno y casi 10.000 personas por alguna enfermedad relacionada con la contaminación. Este es un mapa satelital de los focos de incendios en Sudamérica. Esto es Brasil y aquí tenemos Argentina. Y tenemos esta terrible estadística donde si bien Brasil va a la cabeza con 139.000 focos de incendios que tienen un 12% más que lo que tenían previamente, Argentina tiene 51.000 focos y tiene un 171% comparado a imágenes previas que se tenían. Se sabe que según la ONU, para el 2050 habrá 30% más de incendios forestales en el planeta. Y esto realmente es preocupante. Porque todas estas sustancias, todo este material particulado está en el aire, lo respiramos todos y también lo respiran las personas que viven con enfermedades respiratorias. También hay tóxicos en el ambiente como el óxido de azufre, de nitrógeno y los compuestos volátiles. Todo esto genera ozono troposférico también. Y esto, como mostró en su momento la doctora Jan Williams, va de acuerdo al tamaño ingresando en el pulmón. ¿Y qué produce dentro del pulmón? Produce estrés oxidativo. ¿Qué es esto? Básicamente, produce cambios epigenéticos y produce inflamación. Y esta inflamación es lo que lleva a generar asma y a generar COPD y a generar también otras enfermedades graves como el cáncer de pulmón y a que estas personas sean más proclives a adquirir infecciones respiratorias. También perjudica el desarrollo normal de los pulmones en los niños en formación, en los niños pequeños. Por eso, de alguna manera justificamos la presencia de todas estas superposiciones. Ustedes habrán visto muchas superposiciones en cuanto a lo que se presentó por la doctora Williams, por la doctora Stock, lo que presento yo y seguramente lo que va a presentar la doctora Javiera Corbalán. Pero está bien que se superpongan estas cosas, porque a través de estas superposiciones es desde donde hacemos la plataforma de trabajo para cambiar la realidad. Es decir, las alianzas con el Grupo de Asma del Noroeste Argentino, con la Sociedad Argentina de Medicina y de Respiratorio, los pacientes siempre presentes, y como dijo Ana, esta parte colaborativa hace que fundamentalmente podamos llegar a juntarnos todos y a proponer leyes nacionales que protejan fundamentalmente a los pacientes, que favorezcan el desarrollo educativo de todos los profesionales que tienen que atender a estos pacientes. Que todas estas personas puedan acceder al tratamiento que les corresponde en tiempo y en forma. Por eso, además, está el aporte específico de IPCRG a través de todo lo que tiene que ver con educación e investigación y con todos los proyectos que se desencadenan y que se van integrando y entrelazando a nivel del mundo. Entre algunos recursos educativos tenemos estos, por ejemplo, que son tarjetas para iniciar diálogos, tanto para pacientes como para médicos, como para farmacéuticos, que muchas veces son los grandes olvidados y que son, digamos, las personas que están en la cadena, que interactúan muchísimo entre lo que es la atención al público y el recibir todo lo que tiene que ver con las sugerencias del médico. También tenemos algunos materiales que sirven para usar adecuadamente algunas drogas, como por ejemplo los broncodilatadores de acción corta, como vemos aquí. Materiales específicamente para lo que son los médicos de atención primaria, son materiales que están diseñados específicamente para que sean concisos, de rápida lectura, de contenido, digamos, bien concreto, y que eso haga que estos médicos que normalmente tienen una gran demanda de atención, mucho trabajo, puedan incorporar el conocimiento en forma rápida y correcta. Y, lógicamente, lo mostró Jan en algún momento, el video How We Breathe es impresionante como para que todos lo puedan ver y puedan entender de qué se trata cuando hablamos de aparato respiratorio, de qué se trata cuando hablamos de enfermedades obstructivas, de asma y de COPD. El programa Teachers, que lo nombró Ana, se realizó a nivel global y lo terminamos de realizar hace escasamente 2 meses en Argentina y Chile. Hemos formado 20 profesionales. Estos 20 profesionales fundamentalmente van a desarrollar trabajos colaborativos junto a los médicos que les toque ahora educar. Y la idea es que puedan hacerlo y llegar a todo el grupo de atención primaria de la salud, médicos de familia, médicos generalistas y médicos clínicos. Fue un programa muy exitoso y esperamos ver más resultados con esta estrategia. Utilizamos también, perdón, me desconecté. Hola, ¿estoy ahí?
Te escucha, Sergio, sí.
Sí, te escuchamos.
Perdón, discúlpenme, pero pensé que se me había desconectado.
Ahí
ya,
se ve
ya
de
termino.
nuevo.
Bien, perdón, ya terminamos. Me faltaba solo un slide. ¿Se ve?
Estás en modo común, no en presentación.
En modo presentación, sí, ahí está.
Ahí está,
Se está
estamos
poniendo.
reanudando modo presentación. Ahí está. ¿Se ve ahora?
Espera, todavía no.
¿Sí?
Todavía no.
Bien.
Ahí está.
Las estrategias que utilizamos, según lo que mostró Ana, son estrategias multiplataformas, porque el asma es una enfermedad heterogénea y además es una enfermedad que está tanto en los niños como en los adultos mayores. Tenemos que ser lo suficientemente flexibles y inclusivos para poder a todos debajo de este paraguas. Es decir, que publicaciones en periódicos, en la televisión, videos para capacitar a la gente en el uso de dispositivos, a los pacientes, todo sirve. Digamos, guías de desarrollo para profesionales que tengan que leer asma, todo sirve y todo suma. Por eso mismo, la idea... La idea es que es tiempo de realizar un cambio que entre todos podamos aportar algo nuevo, algo que realmente pueda torcer estas realidades y les pueda dar a la gente que vive con asma una calidad de vida igual a las que no lo tienen. Por eso, de alguna forma, propongo y abro, digamos, la posibilidad para que todo aquel que quiera se sume y colabore con nosotros en esta nueva idea y en esta nueva estrategia que tenemos. Les agradezco mucho. ¿Podemos pasar a Javiera?
Tenés que dejar de compartir, Sergio.
Sí, estoy en eso. Stop share.
Ahí sí. ¿Te escucha?
Sí, sí te escuchamos.
Hola. Hi, I'm Javiera Corbalán. I'm a family physician from Chile, and I will try to speak in English, so if you don't get something, please forgive me and ask at the end. And I will disconnect my camera because we have here a spring storm, and I have an unstable internet connection. So sorry for that. ¿Me confirman que se vea?
Sí, sí se ve. Pon en modo presentación, falta. Ahí está, se ve.
Well, I will talk about our national asthma story. In Chile, we actually don't have adult asthma prevalence data, but we know that 24% of the population have chronic respiratory symptoms, and 10 have had wheezes in the last year, but only 5% have known asthma. So we are most probably facing around 50% underdiagnosis. In adults, asthma deaths are decreasing, although they are 6% of all deaths, and being the respiratory diseases the third leading cause of death globally in our country. In children, we do have data, but they are 20 years old, and our prevalence of asthma ranges between 18% in children and around 15% in adolescents. Fortunately, the death rates are very low. And what have we done? First, in the 80s, asthma wasn't really a topic, and the problem was another thing. We have decreasing rates of infant mortality, but they began to rise at the expenses of acute respiratory diseases. And the study showed that most patients were under 6 months and from a low socioeconomic background, had recurrent wheezing, and they die mostly at home because of viral pneumonias. In the early years, after democracy returns, the Ministry of Health implemented a nationwide primary care-based respiratory strategy to counteract these figures. It's called the National ARI program, from acute respiratory infections. Keystones of this program were to put special respiratory practices inside primary care centers. They include trained physicians, physiotherapists, and nurses, and we call it the ARI rooms, or Salas IRA. They develop widely available clinical practice guidelines and treatment protocols for obstructive diseases, and they transfer technology and resources. We had a widely available reliever and control inhalers, and also spirometries in almost every primary healthcare center. And they organized public education campaigns, teaching parents to recognize alarm signs of severe disease, for example. And finally, there was a dictation of laws for explicit health warranties for acute and later also the chronic respiratory diseases, focusing on universal coverage and financial protection. In record times, we have had big results. The emergency department referrals, hospitalizations, and infant mortality were reduced, as shown in this graph, with almost 19 90% of reduction of pneumonia mortality. Compared to other countries in the same time, it was quite impressive, and it still is a big success history in Chile. This reduction of mortality was inversely related to the creation of these ARI rooms, las salas Ira, along the country, and showed a similar effect on elderly mortality. So we could really be proud, and we were doing fine. We have delivered the service, we trained the health workforce, and we share information, we made available drugs and technology, we secured the financing and lead effective innovation. But nowadays, the pneumonia mortality isn't a big issue anymore, at least for children, and the strategy has evolved. The ARI rooms, the salas Ira, started to take care of asthmatic children, but things went really not the same success path than before. Despite the health guarantees and the guidelines, we can show a very low coverage for asthma in primary care, where the average hides a much worse situation for adolescents. Good control or well-controlled asthma varies from 50% in those being reviewed periodically to under 5% in those without checkups, representing the leading cause of DALYs in 5 to 14 years old. And asthma hospitalizations are rising between 30 and 160%, although it's a largely preventable cause. And a lot of things could happen here. We are facing the effects of health system fragmentation. The resources are spent mainly on cardiovascular diseases. Services keep putting the focus on exacerbations instead of addressing the chronic inflammation. And the last update of our asthma guideline was in 2011. The health professional education initiatives almost disappear right now, and the public campaigns still care about the acute disease and the alarm signs instead of talking about inflammation, like Sean mentioned before. And also key actors in asthma management, like school communities, have not been involved. In this scenario, there's really a lot to fix, and as GRAP Chile, we are talking with the Ministry of Health, promoting these changes. And as a family physician working in primary care, I really hope that the respiratory programs and guidelines will be updated considering our primary care perspectives. But we are pushing for two things that cannot stay out of the radar this time, and that is the psychosocial determinants of asthma and climate change. And I will explain why it's so important for Chile. Statistics are tricky, you know, and it's necessary to interpret Chile's development with caution. Although we are part of the OCDE since 2010, and this year we actually lead the Human Development Index in Latin America, our averages hide a lot of misery, really. Actually, we are the most unequal country of the OCDE, similar to Namibia, Botswana, or Central African Republic. In our country, less educated mothers have 6 times more risk to experience infant mortality. Children from poorer households have much more risk of being severely beaten up. Many families have to live in sacrifice zones where different industries pollute the environment unrestricted. And you can even die from COVID almost 6 times more if you live in La Pintana instead of Vitacura. And when it comes to asthma, this inequality really matters. Recent guidelines have finally considered the increasing amounts of evidence that link chronic psychosocial stress to asthma development and progression. Parental stress, maternal depression, stressful life events, all associates with an increased risk of asthma onset and morbidity, and having asthma increases psychological symptoms, like Sean mentioned before, making it necessary to develop more integral approaches addressing these issues. Low health literacy, like the one Afghan girls are facing today, are linked to lower asthma control, and asthma is the main cause of school absenteeism. That's really important in terms of future development of these children. Poverty, in this multidimensional way, determines more undiagnosed asthma prevalence and morbidity, and it's not only because of lesser access. Communities with high violence, like in Central America, are linked to an increase in asthma symptoms in general, and belonging to an ethnic minority, like the Mapuche people in southern Chile, puts you at risk to have less well-managed asthma, less guidance-based treatments, and less asthma care plans or even appropriate prescriptions. And although asthma deaths in children are rare, Black children in the United States have 6 times more risk of dying of asthma, beyond the genetic factors. Isn't this unfair, just to die more because of your skin color or your ethnicity? If we want to ensure healthy lives and promote well-being for all, we need to urgently visibilize this intersectionality and fight racism and discrimination in health everywhere. And we, as shown before, we cannot rely on good national averages if we don't look under the carpet, because sometimes these averages hide misery. The second issue we cannot forget this time in Chile, and I think globally, when we face asthma, is the importance of environment. More than 1.7 million children die each year because of environmental damage, and of course, asthma is also involved. Children are a major risk group. They have an increased susceptibility to pollutants. They breathe faster than adults, and their metabolism is faster. The immune system is immature, as the lungs are, and they spend more time outdoors, closer to the ground where the pollutants concentrations are higher. Children are fragile, as little animals are also, and we have to care about them. There are a lot of pollution sources and specific pollutants, and some of them, for example, tobacco smoke, can alter lung development even previous to conception, and of course during pregnancy. And we will think about children being exposed in 40% of the time to secondhand smoke. It's a lot. We are risking our children. The effects of pollution are really well documented now. We have long-term exposures that has been associated with immune system changes and increased systemic inflammation, increased risk of sensitization to food and inhaled allergens, to having respiratory symptoms, but also persistent wheezing and asthma onset. And short-term exposures have been associated with poor asthma control, decrease in lung function, increased rates of rescue medication use, emergency department visits, and hospitalizations for asthma. Even if we know that asthma outcomes are multifactorial, there seems to be an important window for prevention, both of asthma onset and exacerbations. And that's important because if we work in this fashion with the children, we can actually avoid that they have asthma in the future. So it seems that it's worth it to think about this. when it comes to climate change, there are some direct effects on asthma, because when carbon dioxide levels rise, some trees and plants make more pollen, and the pollen is more potent. Warmer weather also allows trees and plants to start making pollen earlier in the season, so you have longer pollen seasons. And more pollen exposure increases the risk of allergic asthma exacerbations. Heat waves are becoming more and more common and can trigger asthma attacks. And climate change is making wildfires worse, as Sergio showed. The smoke from wildfires can spread hundreds of miles, and for asthma sufferers, wildfire smoke can trigger symptoms. And when plants are surrounded by high carbon dioxide levels, they develop mold spores that are more powerful even. And climate change also increases severe weather events such as storms, flooding, and heavy rainfall, and that damage the homes, the schools, and other buildings where the children live, and that could increase indoor mold. And whether the mold is indoor or outside, mold triggers asthma. And smoke, or ground level ozone, is a powerful lung irritant formed when chemicals from different sources mix with heat and sunlight in the air. And of course, when it irritates the lung, it could form more inflammation and therefore exacerbate asthma. If we miss these risk factors, we would be failing at our patients, and not only because of asthma. As the single biggest health threat of our time, climate change is a health emergency. And while no one is safe from those risks, as usual, the people who are worst off are the people who contribute least to the problem and who are least able to do something about it. As health professionals, we need to speak out about it, to advocate, as in promote those social, economic, educational, and political changes that ameliorate the suffering and threats to human health and well-being. If we don't, we are violating the very principles of our professions. And it's worth it, because reframing climate change as a public health problem has generated the necessary public and political support to accelerate the adoption of sustainability solutions, inspires sustainability efforts with policymakers, improves sustainability within the healthcare industry, and motivates sustainability action by others. So, if we want to address chronic respiratory diseases, especially asthma in children, we need to change course. How can we help him? We cannot longer rely only on biomedical approaches or just focusing on SABA access, salbutamol access. We need to solve structural health system problems, strengthening primary care services, and improving disease management in an integrated fashion, considering education for health workers and families. For preventing asthma onset and exacerbations, we will need to consider the wider context and address inequalities, empowering communities, and through multisectoral action and policies. We will need solidarity to level the field for everyone, sharing effective ideas between countries, for example. And we will need to embrace advocacy for climate change and pollution action as an ethical duty, promoting sustainable health innovations where we explicitly do not contribute to the climate problem, because health systems do contribute. We'll also need, integrated research, also, so that means more science, where all these aspects combine to find the most effective programs for asthmatic children, anticipating worsening asthma trends, and also being clear that not the same recipe will fit everyone. we will need to adapt to the local context. And now I'm finishing. Breathing free and healthy is a human right, especially important in children because of their susceptibility and developmental needs. Preventing asthma onset and exacerbation is possible. We need just to integrate the different perspectives. Asthma right care is needed to improve disease management and burden. So export this model of approaching asthma could do good to a lot of people and patients, families, and communities. Only multisectorial action will address the disease inequity and its structural determinants. It's not a problem only of the health sector. So we need to address it with the others too. And climate change impacts asthma and needs urgent action to stop adverse health outcomes, not only for asthma. So to reach this sustainable development goal, we absolutely will need the other ones too. And we are just inviting you to go for it together. Thank you.
Okay, thank you, Javiera, Ana, Shan, for your excellent presentations. We invite everybody to activate the micro and ask the questions that you want. We are very glad to answer them.
Okay. Okay. I have a question for you. I think the guidelines are very extensive. It's a very big problem, the guidelines. Do you think that, or do you believe that we should adapt the guidelines to the primary care to make them more accessible or more simple? What do you think?
Well, I mean, our primary care colleagues always want things simplified because they are given a guideline by every professional society for every disease. So if every guideline is 20, 30, 40 pages long, there's no way they can manage it. So yes, but on the other hand, you have a new GP, somebody with 1 year's experience, and you have somebody with 30 years experience, and they don't need the same guideline. So there's a whole industry of people saying, actually, guidelines are not what anybody needs. It's not how people make decisions. The first thing we need to do is understand what prior knowledge somebody has. And so there's this suggestion of mind lines. So if you are a GP who's very confident in taking a history, you just need a bit of information about the current best practice in prescribing. You need something different from somebody who's not familiar with asthma, quite new to taking a history, and needs more information. So we have to find different ways of presenting the information. But I think one of the challenges with asthma, and our colleagues in Tunisia and Vietnam have told us this, is that in medical school, asthma is still taught as a problem, firstly, of bronchoconstriction, and secondly, of inflammation. We've known for over 30 years. Sergio showed that slide of, the story, but that story is still not right in many medical schools. So that's not about simplification for primary care. That's making sure that much earlier in the career of a healthcare professional, they're given the right story about asthma. So I think it's a combination of things. Yes, we can simplify. We have to make it relevant for the individual's level of experience and confidence. We also have to recognize it depends on what drugs are available. So in some countries, there is only short-acting beta agonist. So the guideline that says anything apart from that is not helpful. What we want is to influence the World Health Assembly so that inhaled steroids are available everywhere, and probably in combination, but that would be nice. If those medicines are available everywhere, then it becomes easier to explain what to do.
And Sergio, what do you think?
Well, I obviously share with Sean, because if not, I will be dismissed from Argentina as Malakia. No, the concept is that, I am thinking that the problem of guidelines are the staircase kind of treatment, and obviously the kind that as a staircase they try to set if it is one in one severe statement or not, you can use or not some or another thing. I think that it is this partition of the treatment may make a lot of problems. I think that we have to go away and to abandon that kind of guidelines. It's about what we have been discussing the other day, Anna, from using one star or for asthma treatment because the patients do not know about to be in one or another star. They are moving from one along the life and to be in another part. Vos sabías, Ana, de eso. No sé si lo querés comentar.
I think it's important that in Ganoa now we teach in the primary care that not the patient is not step 1, step 2, step 3. I have a new project to teach in the primary care the precision medicine in asthma since from primary care, not a specialty, from primary care. And we have a new project for this, and then we talk about this, but I think it's important to adapt the guidelines to primary care and to not only the physicians, also the pharmaceutic, the nurse, other people who work in the primary care. Javiera,
¿viven acá en Corrientes Capital?
Sí,
y contame, ¿los mandó algún médico? ¿Vinieron solitos?
Vinieron solitos,
Bueno,
pero porque venimos haciendo un tratamiento.
Alejandro, tenés activo el micrófono.
Alejandro Berardi, tenés activo el micrófono. A ver si lo puedo.
Está una vez por semana, más en los cambios de clima.
No sé si vos lo podés mutear.
Y bueno, lo llevé el año pasado a Pigari.
A Pigari. Alejandro. ¿Y ahí quién te lo vio?
Alejandro,
lo vio,
tenés tu micrófono activado.
Ya lo llamo por teléfono, Ana.
Se está llamando. ¿Está en un congreso?
Es un foro de
Alejandro.
Alejandro, tenés el micrófono activo, Ale.
Apaga el micrófono. Ahí está.
Ok.
I'm
Javier,
not sure if it makes
guidelines.
Speak in English, but I'm doing my best. I think we need to consider two aspects. One is why we still need guidelines. What do we want to achieve with the guidelines? Because the treatments are evolving, and maybe we will need another type or a way to communicate this actualizaciones, updates.
Updates.
And because if you publish the big guideline in 3 years, it's obsolete again, and so it doesn't make sense to me. So maybe we need something more like the NICE guidelines that are published online and like evolve every couple of years. But also, a thing with the guidelines is the implementation, because you can have the best guideline, but if it don't comes down and you cannot use it, so the effort is lost. So we need to think how to bring this information to change conducts of the colleagues. And on the other side, I think we cannot longer wait after the colleagues are out of university, and we need to work in pre-grad medicine schools, because the distance between what the pre-grad students learn about asthma and what we are actually doing right now is huge. I don't understand it, because it's really, really different. And I mean, I don't know if it's a generational problem. The teachers are maybe older, I don't know. But they are focusing mainly on biological aspects. They don't get the patient-centered approaches. I think we need to work with pre-grad students and change the way they come out of university to afterwards make sense of using a guideline with this totally different management style.
Ujú. Okay.
Acá Carlos está haciendo una pregunta.
Ujú. Carlos, hello, thanks for presentations. I also need translation. My Spanish is very bad. I have a question. What proportion of asthma is occupational asthma in Latin America? I am more into safety and health rather than medicine. Thank you.
No, I don't know. There aren't many studies about occupational asthma. I don't know if Chile have, but Argentina know the percentage. In Latin America, there aren't.
Generally speaking, it's about 10%, but the International Labour Organization has just done a study, and I'm trying to get the data because they've looked, internationally, and obviously areas with agriculture, whereas and production, it's going to be higher than 10%. But in Europe, certainly it's about 10%. So you could assume it's a bit higher in Argentina.
Yes. Then we record this presentation, and then I put the subtitles, and then give him. Yes.
Mm-hmm.
Yes, because we have some troubles with translation, automatic translation. So we are going to upload to YouTube with subtitles.
Sí, hay una pregunta, Sergio, de Carlos. No sé si la quieres contestar.
Carlos de Chile.
Sí, dale, Javiera.
As I said before, we don't have adult prevalence asthma data in our country, but we do have some descriptions of the occupations that most prevalent are associated with asthma. And it comes to my attention that bakers, or like the people who makes bread and are exposed to flour, are from concern in our country. But it's described as between 9 and 15%, but we don't have specific data in Chile.
Okay, Carlos tiene mano arriba.
Great presentation. My question is the following. As there are technological devices which can make either patients or HCPs easier the the acceleration to the specialist, to the pneumologist, what would you recommend for us?
So is this technology, what sort of technology?
What sort of technology, of course?
Because, I mean, at the moment, the biggest problem, well, one of the biggest problems is diagnosis, and that there is no technology that will resolve that. That requires proper primary care skills in terms of gathering a good history and encouraging people to use peak flow. So it's not high technology that's required. There's some view that maybe for a personal asthma action plan, you could do that on an app and link it to electronic peak flow, or these things don't exist yet, but maybe they could, but they're not necessary. They're nice. They're nice additions. Basic communication skills should be sufficient, in my view.
Okay. I have a question for Sean, because as you have seen in different presentations, we have some overlap between different movement organizations and well. How do you think that we have to cope to this overlap, to follow the line, to reach the goals that we want for asthma?
So
work.
Yeah, there is there was some work done in Stanford University in the 70s, and it was programming work about how birds flying in the sky, how they flock. How do these birds fly in the same direction, but they don't knock each other out of the sky? They don't fall to the ground. They all fly. Then they might move and go the other way, and they can travel across continents, across oceans, and they each fly, but they don't get in each other's way. And that's what we need to do. And this program was called Boyd's. You have to imagine a New York accent saying the word bird, so Boyd's. And I think that we should think about being Boyd's. And that means that, and they've done programming work about what is happening with birds doing that. And there are 3 simple rules, really. That you maintain the steering of the average steering of your neighbours. You give each person a little bit of space, and there's a third. But basically, this is about complexity and the theories of complexity. The only way it works is to simplify the messages, and everybody can agree on 3 simple messages. Then it doesn't matter what activities they do, because they're all still going and steering in the same direction. And that's what we have to try and do with our social movements, is just agree these simple messages. Asthma is an inflammatory condition. Everybody deserves access to affordable anti-inflammatory medicines. We have to think harder about the diagnosis, but we have to listen. It's a variable condition, so it's unlikely that somebody can get a good diagnosis in one consultation, because the condition varies. You need to build up a picture over time. And if we could agree these simple messages and what we want to achieve, then we can all flock together and not knock each other out of the sky.
It's very good. We have a question from, I think that is Mar Martinez, who is here. Thank you, Mar. What is the change that we can expect of using social movements for health as asthma right care movement for asthma?
So maybe I can try and show a slide. So the point about a social movement is that you have to build on society's interest and desire for change. And So it's about mobilizing. So it's not about telling people what to do, it's about mobilizing it so that everybody in the system starts putting pressure on wanting change. So people have to listen to Javiera's messages and be angry about the damage we're doing to children's lungs. We have to look at the data that Anna has presented about poverty, and we have to fight to give the people in the poorest areas the access to the best care. We have to see respiratory disease as a social issue, not just as a health issue. So the trouble with the social movement is that you can't guarantee where it goes. You can't guarantee it because you have to mobilize people and go where what they think is important. So you have to educate people. But it's, as it says here, it's more of an art than a science. So we have to be cleverer about how we measure the impact and how many voices are heard, and where we see policy change or where we see behavioural change. I don't know whether that helps, but that the good examples include the Green movement, HIV movement have done brilliant work to reduce the stigma. The disability movement has achieved a lot, and now we're seeing, this is Mothers for Air Pollution, we're beginning to see some advocacy on climate change, particularly from mothers about children's health.
Excellent. Okay, is there anyone who wants to ask a question?
No escuché.
¿Cómo? Sergio, se cortó.
Estaba preguntando si alguien más tiene alguna pregunta.
No, yo tengo una reflexión final hablando de Latinoamérica. En este momento soy la vicedirectora de ALAT, la Asociación Latinoamericana del Tórax, que reúne a todas las sociedades del tórax de todos los países latinoamericanos. Yo creo que es una gran oportunidad que tenemos de trabajar en estos proyectos, perdón que lo voy a decir en español, tengo una gran oportunidad de trabajar con estos proyectos desde sociedades latinoamericanas para poder llegar a todos los países. Así que es una gran oportunidad para que hagamos alianzas con todas estas sociedades científicas. I think it's important that this project, Asthma Riker, GANOA, all these projects have alliance with scientific societies like ALAT, Asociación Latinoamericana del Tórax, because ALAT is is all the societies of all countries in Latin America, and it's important incorporate this project.
I agree, and that the success is when somebody other than us tells our stories and uses our slides. If the scientific problem sometimes is that somebody says, "Oh, can I have some slides?" And people say, "No, they're my slides." No, in Asthma Right Care, if somebody uses our slide, it's a success, because that's what we want. We want people to follow and to share. So we have to do everything we can to encourage that idea that sharing the same messages is going to have more power and more impact than everybody thinking they have to come up with some clever new thing to say.
There is actually not so much new.
No, exactly.
And I think that's marvelous. I was thinking about the history of success of these ARI rooms in Chile in the 90s. In Africa, they are still struggling with child pneumonia and infant mortality because of respiratory diseases. And I still believe a lot of these deaths are preventable not with antibiotics, but with inhalers. And that was 30 years ago. So maybe we can shift this experience in this time Chile were considered an underdeveloped or middle income country. We can shift this experience experience to the countries that are still struggling with the same problems. We cannot afford any more children deaths because of something that is so preventable. We are not talking about rare or strange disease. We are talking about breathlessness and wisdom. It's easy to do.
Yeah.
Mhm. Okay. I think that as a final reflection, I consider that asthma is a global or universal problem. We have been focusing in Latin America, Chile, Argentina, local problems. But as if you remember the work of Mark Levy, 2014, why asthma is still killing people. This is a work from United Kingdom. There, people have access for medicines and doctors, and they are a developed country, and they have a serious problem with asthma, and also in another first world countries. So we have a problem, but this problem is across the world. So I think that we have to focus at every ground and start changing simple or different things as we can, and try to start with health policies to change in great scale the problem.
I agree.
Okay. Thank you very much.
Well, thank you, Mar, for your congratulations. Well, if Eric, you are here with us, if you want to shut the session, you can. And thank you for the opportunity of being here. I'm very glad for all your attentions and support.
Sergio, I think it's your session and the session of your co-organizers and speakers. So it would be presumptuous of me to close the session. So I hand back the responsibility.
Oh, terrible. Well, but I am with three distinguished women, so I can't do that. So, Sean, Anna, and Javiera, it has been a pleasure to share with you this session, and I leave to you to share it.
Thank you very much for a very nice session.
Yes, thanks to everybody, and thanks for the good questions. And yeah, it was very hard to know who would come and therefore how to pitch it, but obviously we can talk more about lots of these areas. So if you have questions for us, maybe we can the portal. Yeah.
Sorry, before we close, I'm sorry to interrupt you, Sean. It's really it comes to my mind is that something which I have always repeated during the operational bi-weekly meetings, and I did not introduce that here in this session, is think of this as an editorial or a publication, or where you summarize your conclusions. So you can publish that, and we can talk about it and see what you think about it. Sergio has my phone number, so we can organize, and Anna as well, and Sean as well. Javiera, no. So I think it has a value. The UN will receive the summaries anyhow, but I think if we can make a sort of summary of this session, then that would be it would be a, how do you say, concrete result.
Yes, I think we could do that. Yes, thank you. Thank you for the suggestion.
Thank you. Thank
So
you all.
thanks for all your questions, and we put some links in the chat, so hopefully people have found those, and all our resources are Creative Commons, so you're very welcome to share them, and in fact it would be a delight if we saw somebody else using our slides. So thank you. Have a good day.
Bye bye.
Bye bye.
Bye.
Thank you very much.
Gracias por su
Bye.
participar.
Bye bye. It's a pleasure. Bye.
Bye.